Hello everyone. So today I'm going to go over the disorders of the lower gastrointestinal system. Before we get into all of the different conditions, I want to talk first about the symptoms and complications that are very common in the lower GI. And most of them involve, well, feces. So the first one is constipation, which is generally caused by either not drinking enough fluids, following a low fiber diet, not being active enough, holding your stool too long or too often, changes in hormones, like when you're pregnant, the hormones will relax those muscles, and so you aren't able to move it through maybe as easily, and so sometimes we see constipation more frequently in that population. We also see it in certain disease states and certain medications. The treatment is to basically fix the stuff that caused it. So we do a gradual increase in fiber. We never want to go too quickly or too much because it can cause constipation, and we need to make sure that fluid increases along with the fiber. And then, of course, more exercise that someone gets, the more stimulation there is to the lower bowel to keep things moving through. What are the foods that are high in fiber? Well, these are the whole foods. You know, the whole fruits, whole vegetables, whole grains, legumes, which we also refer to as pulses. These are not cooked terribly much, so they're going to be more steamed, roasted whole vegetables, fruits that are not canned, but they're in their natural whole form, and of course the whole grains and legumes. And then I also just wanted to add the idea of how we use the restroom. So if you go back to the beginning of time when humans came to this earth, we didn't have toilets. So we naturally are supposed to squat. That's the way it was intended. And so our bodies are designed that way. And if you look at this sitting position here, if you're at a 90-degree angle like you would be on a stool, it actually pinches this rectum and prevents the stool from passing through as easily. So what we do is get into this more of a 35-degree angle where you're more like a squat, and that helps kind of open up that area so that it comes out more easily. And yes, that is where I think it was on Shark Tank where they came up with the squatty potty. That's where that came from this actual physiology of the body. The next symptom is gastrointestinal gas. Of course, we've talked about this a little bit here and there because it does tend to happen when we eat foods that are high in fiber, because the bacteria feed off of the undigested fibers and resistant starches, and they produce gas. It also can be related to disease state in addition to your diet. So we have a list of foods when gas is a problem. Ones can maybe limit from their diet. Again, this is just something that we want to limit the symptoms, make things a little bit more comfortable for individuals. It's not something that is going to, be life-saving or anything like that. And then we'll talk about the FODMAPs a little bit later in this discussion. And the final complication or symptom that we see is diarrhea. And diarrhea is something that is generally caused by either disease or medication. It is not something that is caused by diet. Something's going wrong in the intestinal tract if you're experiencing diarrhea. And our concern with diarrhea is that things are moving through too quickly, and it's going to contain a lot of the fluid that would normally be reabsorbed into the body. So we have a lot of loss of fluid and electrolytes, which can cause dehydration and electrolyte imbalances. And remember, our electrolytes, potassium, sodium, and chloride, these are very significant to many functions in the body, including muscle contractions with the heart and nerve reactions. Then we also have potential problems with weight loss and malnutrition because of nutrients that are not being absorbed. So with diarrhea, ultimately our goal is that we fix the underlying condition that's causing the diarrhea. That's first most important. Continue the rehydration of both fluids and electrolytes. And we can avoid foods that tend to cause more problems, like high fiber foods, high fat processed foods. Those are the ones that usually cause the most difficulty when you have diarrhea. And then we can increase or decrease fiber based on how the individual is tolerating it. In some cases, the fiber, especially soluble fiber, kind of helps bulk things up a little bit. And in other people, it just makes the diarrhea worse. So we just kind of have to play it by what works best for the patient. Okay, so now that we are finished with the symptoms and complications, let's dive into some of the conditions that are likely to affect the lower GI. So we're kind of working with everything that is south of the stomach for the lower GI tract. And the first thing that we come up with is malabsorption syndromes. So when we were talking about how foods are digested and absorbed, there were several that kind of created an issue for us. And the most common problem that we have with malabsorption is fat. Fat malabsorption is problematic because we have requirements for bile to first emulsify the fat before it can be digested and then absorbed, which means we are involving multiple organs systems. So we have the liver that's producing the bile, we have the gallbladder that stores the bile, and then we have the pancreas that makes the enzymes to digest fat. So it's quite common that this is going to be an issue for us. I think I even mentioned back in the very beginning how fat always causes us problems. So you see a couple pictures here. These are two different forms of the malabsorption syndrome that we would see with fat malabsorption. We call this type of symptom that you see in front of you steatorrhea. And steatorrhea is a foul smelling, like nothing you've smelled before, diarrhea with pieces of fat. Sometimes it is frothy, and it just is diarrhea, and it can happen multiple times throughout the day when someone has fat malabsorption. It's a very uncomfortable thing to have, and it causes a loss of energy because you're not absorbing fat, and fat is our biggest source of energy because it has 9 calories per gram. We lose some of the essential fatty acids, actually a good percentage of them. We're not able to absorb the fat-soluble vitamins, and we also lose some minerals like calcium, magnesium, and zinc that make it more susceptible to forming kidney stones. When someone has fat malabsorption, we may recommend a fat-restricted diet. The normal reason that we would choose to do a fat-restricted diet is if steatorrhea is present, because it is a very uncomfortable symptom and it's a true sign that things are going through way too fast and we are likely having more than just a minor issue. So if steatorrhea is present, we are likely to restrict fat. Note that this has to do with all fat. It is not a difference between good fat or bad fat. So in other words, it's not the type of fat, it's not unsaturated, saturated. They all are going to be digested and absorbed in the same way, and they all become a problem during fat malabsorption. Now, one thing we can do is include something called MCT oil. MCT stands for medium chain triglycerides. If you recall, that was one of the ways we could tell the difference in fats, was by the chain length. We had short chain, medium chain, and long chain. And the nice thing about the medium chain is they can be absorbed without lipase or bile. So those medium chain triglycerides that we were complaining about with coconut oil, those actually are absorbed easier. So those kinds of fats can be included in this diet. We actually have this special oil that we would use that we can add to our foods. And this is going to provide the calories that they need. Now, it's not going to provide the essential fatty acids because those essential fatty acids are long chain, but at least can get the calories in for them. Now, on a fat-restricted diet, we mentioned it's not the type of fat, but just all fat. So, the limiting of our foods of all these different types of high-fat meats, high-fat processed meats, avocados. I know they're a good type of fat, but remember this is all types of fat that we need to limit. Whole dairy, milk, yogurt, and cheeses, nuts, and oils of all kinds should be limited. And this is not something that we are eliminating from the diet, but limiting to resolve some of the steatorrhea. The next two conditions that we talk about are significant for this fat malabsorption issue that we were just talking about. So let's talk about the conditions that affect the pancreas. So the main thing that we find as a problem for the pancreas is what we call pancreatitis. Now it can be both acute and chronic pancreatitis. And what ends up happening is that the pancreas becomes inflamed, and that affects how the pancreas is able to function. So one of the things that we have talked about in the past was that the main function, or one of the main functions with pancreas, especially in regards to digestion, is that it makes the enzymes that are necessary to digest carbs, fats, and proteins. Now, the pancreas does not wait to make these on demand. They actually make these enzymes ahead of time, but they don't activate them until food has come into the small intestine. So as it enters into the small intestine, it triggers for the pancreas to activate these enzymes, and then it's going to send it into the pancreatic duct so it can go to the small intestine where it would digest your carbs, fats, and proteins. So the problem is that when your pancreas becomes inflamed, it activates those enzymes that are in there. And the problem is that some of those enzymes happen to be proteases, or the ones that break down proteins. So it will start to break down proteins. Now remember, all cells are made up of protein. So that means that everything in this pancreas is subjected to being denatured, or digested, so it all should be broken down. And so we end up with loss of some functions of the pancreas. And what we're going to find is that when individuals eat, it causes a huge, tremendous pain, and that has to do with this activation of these enzymes in the pancreas. Now, an acute attack or acute pancreatitis is a short-term duration of this. When it becomes a chronic condition where it's happening repeatedly over and over and over again, the damage to these cells becomes permanent, and we start to lose function with things like the beta cells that create insulin. And so long term, we can have some damage to the ability to manage blood sugars. So there are various reasons why people have acute pancreatitis. Gallstones, as you see in the picture, was one of the things that can lead to pancreatitis because it blocks the ducts where the pancreatic duct goes into the joins with the bile duct. So in addition to gallstones, we have alcohol consumption, smoking, drugs, and certain toxins that can also lead to acute or chronic pancreatitis. I mentioned the abdominal pain as one of the telltale signs of this one. As a matter of fact, pretty much any time you have such severe, unrelenting pain that is worsened by eating, it's probably the pancreas most of the time. And that can happen whether it's pancreatitis, or even we see it with pancreatic cancer as well. So one of our main symptoms is steatorrhea. Again, I mentioned that these particular disorders or conditions that we're talking about have to do with the fat malabsorption issues. So weight loss and malnutrition are very common in this population, especially the longer it goes. So especially as it becomes a chronic condition, weight loss and malnutrition are going to be problematic for us. And we can have difficulty with controlling our blood sugars because of the reduction of insulin and glucagon in chronic conditions. So the way that we treat this, or what we call medical nutrition therapy, is we want to reduce malabsorption and correct any malnutrition. That's kind of our long-term goal. Now, pancreatitis is one of those that typically we do nothing by mouth or NPO when the symptoms are really severe. Most of the time, especially with acute pancreatitis, we're talking about 7 days or less. Usually, it's a fairly short-term thing. And we can manage it with just fluids and electrolytes because it is short-term. Eventually, we can, once those symptoms start to improve, we're able to progress the diet. And we'll do a routine progressive diet with it going from clear liquid, full liquid, to a fat-restricted diet. And then eventually back to regular foods, unless it is a chronic condition. If it is chronic pancreatitis, we stay with a fat-restricted diet. We talked about those foods that would be restricted with a low-fat diet. And then we also will provide pancreatic enzyme replacement. So pancreatic enzymes are these little pills that have the enzymes already in there. So basically the pancreatic enzymes, that our pancreas is making, and they put it in this little pill. And it's encapsulated, whatever the word is I'm looking for. And so that way it gets through the GI tract. So it will go through the stomach, but the acid won't break down. It'll start to slowly erode the encapsulation, but it's not going to affect the enzymes because that coating that is on it. And so by the time it gets to the small intestine, it will have, that acetic acid will have eroded all of the outer coating away, and then those enzymes will be safe. And so when it gets to the small intestine, then it can still break down those foods. The second malabsorption issue that we run into is a condition called cystic fibrosis. Now, this is a genetic condition, and so this is one of those that we would have talked about back in the protein chapter when we have those inborn errors of incorrect sequencing of the amino acids. So this is one of those. So cystic fibrosis, in this incorrect amino acid structure, these proteins are made incorrectly. So this mutated gene results in thick mucus secretions instead of very thin ones in the exocrine ducts. So all of your organ systems are going to be affected. It affects lung disease, and that's because it is the thick mucus in these lungs. It interferes with oxygen being exchanged in the lungs. The pancreas, the pancreatic ducts, we just looked at the bile duct and the pancreatic duct that come together to go into the small intestine. That becomes clogged up from this thick mucus, and we can't get the pancreatic enzymes down into the small intestine, so we are not able to digest, so they end up with malabsorption. And then this mutated gene also causes an increased amount of sweating with excessive loss of enzymes, I'm sorry, not enzymes, electrolytes, so sodium, potassium, and chloride. So in this particular disease state, because so many things are altered, breathing, digestion and absorption, sweating, these are all functions that are not working properly, and in order for the body to try to make up for these functions, it's working in overtime, which means it needs more calories. It's hypermetabolic. So we are going to have a need for more calories. We are going to have malabsorption. And then because we are not able to get these enzymes working correctly in the pancreas, we end up with potential for pancreatitis and changes to that pancreatic structure that can break down our insulin production and eventually lead to diabetes. So the treatment for this population, even though they're malabsorbing, they are so malnourished, so low in weight, that we cannot afford to give them any restrictions. This population, because it's genetic, usually starts in childhood, sometimes infancy. It generally will be in infancy, but we may not see the long-term effects of it until they get into their childhood. So we're talking a very long time. These folks don't live as long. I think the life expectancy is about 52 years of age. and I believe the mean age is somewhere in the 30s. So this population is always going to have difficulty breathing. They're going to have constant infections, which again increases their caloric needs. But when they eat the food, it's not digested, so it goes straight through. So these individuals will often be constantly hungry because they're not getting those nutrients. So they'll eat large amounts of food, it'll go through undigested, and they end up with very large, bulky stools. They're underweight. They often have poor bone structure and poor muscle structure and low fat in their bodies. So these are very small individuals. We cannot afford to restrict them. So the diet that we use to treat cystic fibrosis is a high calorie, high protein, liberal salt diet. So it's the only good diet you get to have. The disease is terrible, but at least the diet is good. What we usually say is eat anything and everything you want, double the portion size, and add a little salt to it. Of course, we will need to give them multivitamins and minerals so that we can help with help get all the nutrients they need, and then enzyme replacement will be necessary with all their meals as well. So once again, those encapsulated enzyme pills. All right, so now let's move into the small intestine. These are several conditions that affect the small intestine, and you'll notice that this is going to include more malabsorption, but not necessarily specific to fat. So we're going to have some different issues that are in play with the small intestine. The first one that pops up is celiac disease, and this is probably one that you've heard of before. Now, again, just like we saw with cystic fibrosis, celiac disease is a genetic condition. This is hereditary disorder, and in this one, it's just a little bit different. It's more like an autoimmune disorder. So the immune system mistakenly attacks the intestinal cells when gluten is present. Now, gluten is a protein that is found in many of our carbohydrate-related foods. So it's actually a protein that is found within grains of wheat, rye, and barley. And it's often the case that our body has problems with the protein aspect of things, and that's why the immune system attacks. The problem with celiac disease is it's literally changing the intestinal cells, eating away at them because the immune system is attacking them. So you can see here in this picture how, or we talked about on the inside of the small intestine, it had the villi that were kind of finger-like projections. Well, as those are destroyed by the intestinal cells, by the immune system that is attacking it anytime gluten is present, they slowly just kind of deteriorate away until there's a smooth surface. And that's problematic for us because remember, these finger-like projections, the main function of that was that it increases the surface area, which gives us more opportunity to be able to absorb things. So this is a really big problem for us. And this is just another illustration of it. I was explaining the finger-like projections. Look at the difference between the normal small intestine and celiac disease. So we get to the point eventually where the person is not able to absorb much of anything. And so malabsorption, weight loss, fatigue, anemia, and bone disease are very common as this disease progresses. Now, initially speaking, they're oftentimes not going to notice any symptoms. This is a hereditary disease, yet it's usually not identified or anything really early in life. You know, we're not doing it in infancy. It's usually later into childhood and sometimes even into, you know, the teenage years and potentially even adulthood before we finally diagnose it. And the reason why is because there's just not been enough damage into the intestines for us to notice the symptoms. So the symptoms are not fun. You'll find out in a second, and they are just like many of our other lower GI disorders. But the really big thing about celiac disease is that there is damage done to the intestinal tract that causes malabsorption. And so we mentioned that the foods that contain gluten are the things that are a problem for us. So gluten, as I mentioned, is found in wheat, rye, and barley. So they have to eliminate these foods from the diet. And you may hear people say, oh, my symptoms aren't that bad, I eat it anyway. Not a good idea. If your symptoms aren't that bad, what that basically means is that you haven't done enough damage yet to your intestinal tract, but you're doing damage every time you eat gluten. So this is a strict adherence to a gluten-free diet. Oftentimes lactose does become a problem. Not always. That's one that we kind of have to see how the patient is doing with it. But they eliminate anything that is made of wheat, rye, barley, and then oats are sometimes contaminated. Now, one of the big problems we have is this idea of cross-contamination. You know, it's easy to say, okay, well, don't eat anything with wheat in it. So that's going to eliminate anything with regular flour. So cakes, candies, cookies, bread, pasta, waffles, pancakes, crescent rolls, donuts, cereals. I mean, it's like everything that you love to eat, right? All those carbohydrates are a problem for us. But the problem is there's some cross-contamination that can occur. So, for instance, a cereal company like General Mills, or I'm trying to remember the others that are out there. If you have a company that produces cereal, if you have one cereal that makes something with gluten, any other cereal that is made with the same manufacturing parts are going to have gluten in it from cross-contamination. So in order for that cereal company to have a gluten-free food, they have to have completely separate facilities for them to produce that cereal, because there cannot be any cross-contamination. This is why in restaurants it's so difficult to find true gluten-free foods, because you have to have completely separate kitchens, or areas of the kitchens where you have different people working in different areas where you will not have any cross-contamination whatsoever, because even small amounts of gluten is still doing damage to their intestinal tract. Barley, we do some. Of course, the one you probably think of the most is beer, is made from barley. Rye, we do have some rye breads that people consume as well. Then we have all the places where there are hidden sources. I mentioned the beer, but there are just a whole list of various foods that are likely to contain gluten in it. It's really kind of frustrating for a lot of people with celiac disease, because the restrictions are lengthy. For the most part, you know, with celiac disease, it's one of those that it needs to say gluten-free on the outside, or you need to avoid the processed foods, because they can come pretty much anywhere. Because the fillers that we use in foods, so let's say, for instance, we're going to make hot dogs. The fillers that they put in there, along with all these other types of meats that they're grinding up, they usually use some type of filler in there, and those fillers are starch components that usually come from a wheat product. And so that's a problem for us. Cheese, you know, plain cheese by itself, you buy it in the block, normally not a problem, right? So cheese should not have it. It's a milk-based product. However, when they shred it, the anti-clumping agent they use that coats the cheese so that it doesn't clump up in the bags, that has gluten in it. So they would have to either purchase specially made ones that say no, gluten-free, or they would just buy the blocks and shred it themselves, which honestly I prefer to do because it melts much better. The anti-clumping agent interferes with the melting aspect, so it's actually kind of nice to do it that way. The symptoms of celiac disease are usually very similar. That's diarrhea, cramping, and bloating. It's not a fun, sometimes gas as well. They're not fun feelings. They get worse as the disease progresses, and eventually you get to the point where you start to lose weight, and malnutrition becomes more likely. Now, we've been talking about gluten here. One thing I probably need to mention is that we do have other conditions that are related to gluten being an issue. It's called gluten intolerance. Gluten intolerance is where an individual consumes gluten and they experience very similar symptoms like diarrhea, cramping, and bloating. But the big difference between gluten intolerance and celiac disease is that celiac is doing damage to the intestinal tract that is going to lead to malabsorption and malnutrition. Gluten intolerance, it is not causing damage to the intestinal tract. It still has symptoms that are very difficult to deal with, and there's no reason for somebody to consume gluten if they are having these symptoms. So we tell them to limit those or eliminate those foods from their diet. But if they accidentally got some, it's not going to harm them. It's just going to cause some symptoms that they don't like. And the sign that I hear the most often is the bloating. They will eat something with gluten and they get this bloating, like they can literally have this big stomach that comes out, and it's very, very uncomfortable for them. So still something that we want to pay attention to. So the next disorder is inflammatory bowel disease. We put initials to this. We call it IBD. So IBD is a kind of an umbrella term for two conditions known as Crohn's and ulcerative colitis. So these affect many people in the United States. They are considered autoimmune disorders. And with an autoimmune disorder, the immune system mistakenly attacks healthy tissue. So if this were a matter of hypothyroidism, it would be attacking the thyroid. If it was diabetes, it's attacking the pancreas. And inflammatory bowel disease, it attacks the intestinal tract. The difference between Crohn's and ulcerative colitis, we usually do see some differences in where this occurs. So in ulcerative colitis, it can happen anywhere in the large intestine, so the lower part of the intestinal tract, whereas Crohn's can be anywhere from, as the slide says, gum to bum. So it can happen anywhere throughout, but it's usually in the small or large intestine is usually where we see it. The pattern of inflammation is also really interesting. The Crohn's disease is a much deeper penetration into the small intestine. So when it goes further down, it actually causes this bumping that is more like a cobblestone appearance. And I'll show you a picture so you can see what it looks like. Whereas the other is very superficial. Both cause inflammation, however. Bleeding is more likely in ulcerative colitis. The other thing is that Crohn's and ulcerative colitis both have a high risk of cancer, but ulcerative colitis is a much higher risk for cancer than Crohn's disease. However, the ulcerative colitis, if we need to do surgery, or what we would call a partial colectomy, or removing a portion of the large intestine, normally that fixes the problem. In Crohn's disease, that is not the case. So if in Crohn's disease we have to remove a section of the smaller large intestine, it is probably going to come back. It has a 50 to 75% recurrence rate. So this is the picture of Crohn's disease. This is what I was talking about, how it has a much deeper penetration, and so it produces these kind of protrusions or bubbles. It looks like a cobblestone pathway. And then you see on the left the normal intestine. And then you have ulcerative colitis, which is just in the lower part of the colon and rectum, and this has a much more superficial kind of inflammation, so you see how it doesn't go deep into the tissue. The symptoms for both of these include malabsorption, diarrhea, abdominal pain, weight loss, and potential obstructions in the GI tract. The diet that we use depends upon what symptoms the individual is having. So the different things that might have to be used are a low fiber or low residue diet, which are both basically the same thing, a fat restricted diet, small frequent meals. Sometimes you have to do high calorie, high protein to prevent malnutrition, or if they have malnutrition. fluid and electrolyte balance, a replacement with diarrhea. Keep in mind that in this population, the diarrhea can be really severe. I'm talking 15 to 20 stools a day with blood and mucus in it. So it can get really, really bad. If it becomes such a bad case where the symptoms last for a long-term time period, then we may have to do parenteral nutrition, and it would have to be TPN because of the high risk of malnutrition. So you can see over here in this table, what we're looking at is the symptoms that we just, that I mentioned that we could have. So in kids, it might be growth failure, weight loss, muscle wasting, anorexia, pain, malabsorption, steatorrhea, etc. And then over here on the right side, you can see the dietary measures that we take. So as I mentioned on the last slide, we base the nutrition aspect on what symptoms they are having. So it really depends. If they have steatorrhea, we do a fat-restricted diet. If they're having malnutrition, we do a high-calorie, high-protein diet. If they're having diarrhea, we restrict fiber, so that would be down here, or even if they have a partial obstruction. So this is the management of both ulcerative colitis and Crohn's when they're having exacerbations of the symptoms. Between flare-ups, now this is a condition that lasts your entire life, but you don't have symptoms constantly. So you could go for years with limited to no symptoms, and during those times, we just want them to eat a very healthy diet. But we have individual tolerances because the individual is highly susceptible to food intolerances and food allergies. And this is not unusual because this is an autoimmune disorder, and the food allergies are also an immune response. So it makes sense that we see both of those things together. And so you'll talk to people with ulcerative colitis or Crohn's, and they'll tell you that it takes a while for us to figure out what foods don't worsen their symptoms and make them feel better in between these flare-ups. And then when they have a flare-up again, then we go back to treating the symptoms with the diet. And then we have short bowel disease. So short bowel is when we have to remove a section of the small intestine. And if you remember Mr. Chainsaw Guy, remember we talked about him and we said that we had to remove a big significant portion of the small intestine, and there wasn't even enough to reconnect it to the esophagus, so it was actually just left undone. You can actually lose, believe this or not, up to 80% of your small intestine as long as this last portion of the small intestine, the ileum, is still attached to the bowel. It's amazing, but it makes a lot of sense because I mentioned back when we were talking about the gastric bypass surgeries, and I said that the bowel is able to adapt. So what it does is it thickens and it takes on the responsibility of what happened previously in the small intestine. So it can take on the function of the part that has been removed, which is a really cool thing, because if we look at all of those nutrients that are being absorbed throughout the GI tract, you don't want to lose any of that function. And it's able to adapt over time to take on that responsibility. But the only way that it knows that a portion of the small intestine is removed is that it's getting undigested material through to it. Normally, everything, it goes through all of this part of the small intestine and it's been digested and absorbed, and, fluid has been reabsorbed, and we've had other things going on, and nutrients are no longer there because they're now absorbed into the bloodstream. But here, nope. Everything's just going to go straight into it. And that's a signal to this ileum that, hey, something's not right. This is not the way I usually get it. So it's able to start adapting. That's why it's so important to have this last part of the small intestine. So the biggest problem we have is malabsorption syndrome, because that portion of the bowel has been removed. So initially speaking, malabsorption is very severe, depending upon what portion of the small intestine is removed and how much of it was removed. And that results in weight loss, muscle wasting, bone disease, anemia, hypocalcemia, and magnesemia. Low amounts of magnesium in your blood. That's what I'm trying to say. So, I'm sorry. oops, where did I go? There we go, back to where we were. So, so this short bowel disease, like I said, initially speaking, you're going to have a lot of this, but slowly over time, and it may take 12 months or so, but eventually you get to the point where everything is absorbing back to normal again. And this is, once again, just a really complicated one, but it's showing you the different things that are absorbed at different parts. And so this kind of just gives you an idea, once again, about the different nutrients that we're going to have issues with, depending upon what part of the small intestine is removed. This intestinal adaptation is going to begin soon after surgery, but it may take, like I said, it can take up to years, but within 12 to 18 months, we should see it back to normal, just like we did with gastric bypass surgery. Now, if we want to make this a little bit faster, we can use a protein or amino acid called glutamine. That will enhance adaptation. The other key to helping with this adaptation is early nutrition intervention. That bowel that is left needs to know that there's a portion missing, and the only way it's going to know that is if nutrients are going through the GI tract. So if you recall back when I was talking about Mr. Chainsaw Guy, I said that we started a tube feed and he didn't tolerate it. So we couldn't just say, oh, sorry, you're going to survive your chainsaw going through your gut, but you're going to die of malnutrition. No, we couldn't do that. So what we did was we switched him over to parenteral nutrition, a TPN, so we could get all of his nutrition that way. But what I didn't tell you is we didn't stop the tube feed. We actually kept the tube feed going at a very, very, very slow rate, just to get nutrients in there, not enough to cause symptoms, but enough to cause the bowel to start adapting. So that small bowel, or the small intestine, starts to adapt as it goes through. And can you believe that this man ended up going home on a tube feeding, and it wasn't even one that was broken down, like the elemental and ones that we talked about? No, he went home on a normal, it wasn't Ensure, it was a different type. It was called Jevity, but it was equivalent to Ensure that he went home on. So it was really an impressive thing because it was only several months later and he was already absorbing pretty well. And finally, we get to the conditions of the large intestine. So the first one that pops up is Irritable Bowel Syndrome. We call this IBS. Not to be confused with IBD. IBD was Inflammatory Bowel Disease. That was the autoimmune disorder that involved both colitis, ulcerative colitis, and Crohn's. This is Irritable Bowel Syndrome, and you'd be irritable too if you had it, I promise. So this one is characterized by having gas, bloating, distension, abdominal pain, and either constipation or diarrhea. You may have seen commercials about IBS as being one with constipation or diarrhea, and then they even have one that has both, alternating bouts of constipation and diarrhea. So this one is less understood than some of the other diseases because it is one of the fairly new ones just within the last couple decades that we have identified it. So what we believe causes this, or at least makes the symptoms worse, is stress, especially psychological stress, and anxiety. We also believe it's related to lack of sleep, excessive coffee, tea, alcohol, and tobacco. We do also believe, through some new research, that some of it may be linked to food intolerances. So this is where the FODMAP diet comes in. The intolerances that we believe to be related to irritable bowel syndrome include a whole bunch of sugars. And FODMAP is an acronym that stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Now, you probably recognize the words disaccharide and monosaccharide, right? So oligosaccharides are just larger sugars, but not quite starches, right? So we do have some of those. And then we have polyols, which are sugar alcohols. So these foods, some of them may cause issues with the intestinal tract in people that have IBS. And so we may have to do an elimination diet with those individuals and see what, if any, of the foods are causing an issue for them. We tend to not want people to just take these foods and avoid all of them. We really want to go through some type of we want to go through some type of elimination diet to see which ones cause the problems. We also have found that probiotics are very helpful. As a matter of fact, if you go to the pharmacy, you'll find that the probiotic section is going to talk a lot about irritable bowel syndrome. They'll have that as the main thing that people that use this particular thing is probiotics with IBS. Stress management, and then there are some medications that can be used as well. So probiotics, I just want to mention real quick, we have talked a little bit about these, but probiotics will help improve the bacterial flora in the GI tract. And I mentioned that we have the good bacteria and we have bad bacteria. And when the bad bacteria get higher than the good bacteria, we call that a dysbiosis. And we don't want that because that's where the bad symptoms start to happen. And it was also related to a whole bunch of other things that we talked about as well. So we want to use these probiotics to help treat several of the GI disorders. We've looked at IBS, IBD, constipation, and diarrhea as potential ones that we can help with probiotics. You can also find probiotics naturally in foods. These are fermented foods such as kefir, miso, sauerkraut, tempeh, and yogurt with active live cultures. And then, of course, we have the supplements that you find in the pharmaceutical aisles. The last of the conditions before we get to surgery is diverticular disease. And we have two forms of diverticular disease. The first is diverticulosis. The suffix osis stands for the condition of. So this is the condition of having diverticula. And diverticula are these pouches. And I know in the picture you're seeing in front of you, it looks more like just holes in the colon, but they are actually pouches, and I'll kind of show you what they look like on another picture. The second one is called diverticulitis. Itis means inflammation. So we have an inflammation of those diverticula. So one means that you have diverticula in your colon, and the other means they got inflamed. Okay, so here's a little bit better picture so you can see the pouches on the outside. The picture before was showing you the inside of the colon, and so you can see how these pouch out. And usually what leads to this problem is that the intestinal wall gets weak and it starts to bulge out, and it becomes weak with age. So we actually see diverticular disease as a problem in older folks, over the age of like 50 or 60, we start to see diverticular disease more commonly. But it also is attributed to a lifetime of low fiber foods. When you're not eating a high fiber diet, remember the insoluble fiber is what pushes it through, like it stimulates those muscles to help keep things moving through, and the muscles also help support the intestinal wall. So having a low fiber diet is problematic for this. Also, constipation is a really big issue. The more you strain and push to try to get stool out, it strains the wall and it can cause bulging out like that. So really we want to try to avoid that constipation as much as possible. So the characteristics of these two diseases, diverticulosis is, like I said, just the presence of having these bulges or the diverticulum. And it's normally asymptomatic. Most people don't even know they have it unless they get a colonoscopy done. However, when they become inflamed with diverticulitis, then it's going to cause some abdominal pain. It can cause diarrhea. Usually it's diarrhea, but there can be constipation or bouts of both. And fever can also accompany it because of the infection that causes the inflammation. I already mentioned the things that it was caused by. And then we have treatment. So we have two different treatments for this disorder. Diverticulosis. If you have pouches in your colon, we want to increase the fiber, especially insoluble fiber, and increase fluid. Remember, fluid is important. We talked about this earlier because that helps keep things moving through nicely. Without enough fiber, you would end up constipated. Now, some doctors will still prescribe avoiding nuts, popcorn, and seeds because they believe they get caught in the little pouches and lead to inflammation. That has pretty much been disproven in research, but some doctors still prescribe it, so it's something you need to know about. Diverticulitis, that becomes inflamed. We need that area to heal. If it's infected and inflamed, we've got to let it heal. So we're going to do NPO and do fluids, either IV fluids in the hospital or just regular fluids at home, but no food for them while it heals. Once the symptoms start to subside, then we can introduce clear liquids and progress to a low-fiber diet. After about 6 weeks on a low-fiber diet, then we gradually increase the fiber and fluids so that they can get back to a normal diet again. Just as a reminder, these are the foods that are high in fiber. So if they have diverticulosis, they would be following a diet that is high in fiber, eating lots of these foods plus plenty of water. If they have diverticulitis, they'd be on a low fiber diet or low residue diet, and they would limit these foods. So what can they eat on a low fiber diet? Well, it's about everything you'd think that we would not say, but for a low fiber diet, it's what we have to do. Canned fruits, 100% juices with no pulp, cooked, well cooked, soft vegetables, and 100% juices like V8. We don't do skins or fruits on the fruits or vegetables. So when I say vegetables, I mean like potatoes. We don't do skins on that, so we would remove it and do more like a mashed potato. Proteins would be from meats, poultry, and fish, and limited amounts of dairy. Believe it or not, dairy has residue in it, and so that is limited. And then your starches should be refined white bread, refined grain bread, cereals, pastas, and rice. So the white stuff with very little fiber in it. So like I said, usually contrary to a healthy diet, but something that we have to do. Remember, this is short term. It's only about 6 weeks, and then they go back to a high fiber diet. And finally, we get to the surgeries. So these are ostomies. When things go wrong in that lower GI with irritable bowel syndrome or diverticular disease or even IBD, we can end up with so much damage that's done to the intestinal tract that we have to remove a portion of it. So if we remove a portion of the lower GI that you see here on this side of the pictures, this would be a colostomy. So we are removing a portion, colectomy, of the colon. And then this would be an ostomy that goes outside of the body. Okay, and so the stool would actually come through here and then go out to this bag on the outside. If we are removing the entire large intestine, then we would take the last part of the small intestine called the ileum, and we would make a stoma here that goes to the outside of the body for all of this to go into a bag. Now these can be partial or total. I have heard of it being not partial, temporary or permanent. I've heard of the temporary ones where, maybe we just need it to heal. And so we need that area to heal for a long period of time. So we'll do an ostomy bag. And then, after several months, they'll go back in, piece things together, and things will go back to normal again. But it also could be permanent. Now, what I want you to notice is that, for like this one right here, we have the majority of our intestinal system intact. So we're not going to see a whole lot of problems with this one. It's just a matter of having a bag on the outside that people won't like. And we'll talk a little bit about that in a second. For the ileostomy, we do have some issues here because we're not using any of the colon. And if you recall, the colon actually absorbs a significant amount of water and takes it back into the body. So we have to be a lot more concerned about fluid and dehydration in this population. We need to worry a little bit more about foods getting stuck in this little pouch here. We'll have a lot more liquidy type of stool. No reason for fiber, because fiber is really for the colon. It's not for the small intestine. So just some things to kind of keep in mind for this population. So I already mentioned all these things already. This is what the ostomy looks like. So it's a little bag. You can see the opening, the stoma here that opens up to the outside, and we attach a little bag onto it. And this bag just sits underneath the clothing, and we attach this bag on, and then when the feces, when the bag fills up, then we just dump it out and put on a new bag. Our diet or medical nutrition therapy that we do for ostomies. We initially do a low fiber, kind of bland diet just to prevent any obstructions and allow things to heal. And then we add food slowly to make sure that the patient's tolerating them. If it's higher in the colon or up into the small intestine, we need to really encourage fluids, avoid juices that promote diarrhea, and maybe increase some of those foods that thicken up your stools just a little bit because it will be pretty watery. No matter if it's a colonostomy or an ileostomy, we do avoid tough, stringy foods that block the ostomy. Make sure they chew well, and avoid gaseous-forming foods. And this is really just a comfort thing for the patients. Nobody likes to have their stool on the outside of their body, and so that bag can kind of fill up with gaseous smells. So going back to the beginning of this lecture, we saw those foods that were gaseous-forming that can be avoided. And that's really their biggest concern is how to prevent the gaseous foods. So here are some of the things, and we also mentioned them previously in the earlier part of the lecture. And that's all we have for this particular section.